Neurology quiz number 54. Discuss treatment of migraine during pregnancy. Migraine without aura typically improves during pregnancy. Improvement is noted in 47% of women in the first trimester, 83% in the second, and 87% in the third. Remission rates are low in the first trimester, 10%, but can increase up to 75% in the third trimester. Migraine with aura is less likely to improve, and new onset migraine with aura or aura without headache can occur in later stages of pregnancy. As pregnant women are often on prescription medication, risk stratification of drugs during pregnancy is important. In 2015, the FDA removed the previously used letter codes for pregnancy risk stratification in exchange for a narrative summary requiring individual review of each medication for a particular patient. Preventive therapy in pregnancy. Number 1, behavioral treatment. As migraines can improve naturally during pregnancy, a reasonable approach is to monitor headaches early on to see if preventive therapy is required. All patients can benefit from lifestyle modifications such as sleep optimization, stress management, adequate hydration, and a regular and healthy diet. Other non-drug interventions include relaxation therapy, biofeedback, and cognitive behavioral therapy. Number 2, vitamins and minerals. Riboflavin and coenzyme Q10 have some efficacy in preventing migraine, but there are few studies in pregnancy. They are not associated with adverse pregnancy outcomes. Magnesium was regarded as one of the safest available options. However, IV magnesium sulfate now has a warning in pregnancy because of reports that it can cause fetal low calcium and skeletal abnormalities after more than 5 days of treatment. Though controversial, single doses of IV magnesium are still used by some clinicians for treatment of status migrainosus. Oral magnesium has not been associated with teratogenic effects and can be considered as a therapeutic option. Number 3, oral medications. Beta blockers like propranolol are generally considered safe and have been used to treat hypertension in pregnancy. However, they can be associated with intrauterine growth retardation, and their use may require close monitoring of fetal growth. Medications that may be safe based on limited human and animal studies include memantine and cyproheptadine, but have not been thoroughly investigated in rigorous trials. Data are lacking regarding pregnancy outcomes in mothers who use SNRIs or TCAs during pregnancy. A meta-analysis of studies on venlafaxine and duloxetine exposure during pregnancy did not find an increased risk of fetal malformations. An association between TCA use and adverse outcomes, including cardiac malformations and pregnancy loss, has been reported but is not consistent across studies. Less effective medications include verapamil with risk of fetal bradycardia and heart block, and gabapentin with risks of preterm birth, growth retardation, and possible cardiac malformations. ACE inhibitors and angiotensin receptor blockers should be avoided because of risk of miscarriage, oligohydramnios, and renal and pulmonary malformations. Valproate and topiramate are not safe in pregnancy. Valproate is a known teratogen associated with neural tube defects and neurodevelopmental disorders. Topiramate is associated with risk of cleft palate. Monoclonal antibodies. CGRP antagonist monoclonal antibodies were not tested during pregnancy. However, there is concern for preeclampsia as systemic levels of CGRP have been found to be lower in individuals with preeclampsia. Given the role of CGRP in preeclampsia, their use in migraine prophylaxis in pregnancy is generally avoided and requires further study. Because of their long half-life, it is recommended that they be discontinued at least 5 months before conception. On botulinum toxin A, initial animal studies raised concern for teratogenesis from botulinum toxin. However, it is thought that the toxin is too large to cross the placenta. Studies in women exposed to botulinum toxin during pregnancy did not show increased prevalence of fetal abnormalities. Most clinicians still avoid using it during pregnancy, while others use it only for intractable and disabling migraine. If used during pregnancy, the risk-benefit ratio should be discussed with the patient, and colleagues in maternal fetal medicine should be consulted. B. Abortive treatment in pregnancy. Number 1, acetaminophen is commonly used as an abortive agent and is considered safe during all trimesters. There has been some concern of association between acetaminophen use during pregnancy and ADHD in children with more than 28 days in utero exposure, though this has not been conclusively established. Number 2, metoclopramide has been established as safe in the treatment of hyperemesis gravidarum and is an effective migraine abortive with or without diphenhydramine when acetaminophen is not effective. Prochlorperazine is also a relatively safe antiemetic, though metoclopramide is preferred. Ondansetron can be a useful alternative for resistant nausea and vomiting, though concern has been expressed for cleft palate and renal agenesis. Number 3, triptans were previously avoided because of concern of affecting the placental circulation. However, accumulated evidence over the years has not shown any evidence for adverse outcomes. They can be offered as an alternative treatment, but should not be used as first-line therapy. Sumatriptan has been best studied and is usually the preferred choice. Number 4, NSAIDs. They should not be used in the third trimester because of risk of premature closure of the ductus arteriosus and other adverse outcomes. Some studies have shown that their use in the first trimester leads to congenital malformations and miscarriages, but others have not shown significant risk. Number 5, lidocaine can be used subcutaneously or with intranasal instillation. No teratogenicity noted in animal studies, but there is limited data in humans. Number 6, IV methylprednisolone has been used for treatment of status migrainosus, but long-term steroid use carries a risk of cleft lip and palate and low birth weight. Number 7, oxycodone is safest among the opiates. It is generally not recommended and should be used only as a last resort. Frequent use can cause neonatal respiratory depression and a withdrawal syndrome. Number 8, ergotamine derivatives are contraindicated as they precipitate uterine contractions, increasing the risk of miscarriage, and they are associated with neural tube defects. Number 9, lasmiditan and Gpan such as rimegepant should be avoided because of scarcity of available information about safety in pregnancy. See other modalities. Occipital and trigeminal nerve blocks can be used in pregnancy, both for acute exacerbation and short-term prophylaxis. Lidocaine is preferred to bupivacaine as the latter crosses the placenta. 2 neuromodulation devices that are FDA approved for migraine include supraorbital nerve stimulation and single pulse transcranial magnetic stimulation approved for both abortive and prophylactic treatment, and non-invasive vagal nerve stimulation approved for abortive treatment. Although not specifically evaluated in pregnant patients, no fetal malformations or birth defects have been observed in post-marketing surveillance or open-label studies.